Okay, I think we can start with some introductions anyway. I don't want to waste any time. We have two short hours to get lots done. So I'm Lisa Kaliza. I'm the PGME education lead developer and CBME co-lead with Parveen Wasi. And I would like to introduce Dr. Laurie Whitehead and Dr. Som Mukherjee, who's going to be your facilitators tonight. They are our curriculum mapping gurus. You're very lucky to have them leading you through the process. They've done a number of maps and a number of similar sessions with other folks, including last year too. So you're in good hands. What we hope to have accomplished tonight is to expose you to the entire process of curriculum mapping and reveal a number of sample maps, quality maps, and a number of templates, and to help you choose which template might best fit your program needs. The session will start with a the session will start with a presentation, and then we'll break out into two groups. You've already selected your groups as to those that are just new into the process of curriculum mapping and those that are a little further along. By the end of the session, what we hope to have is you working through the selected template, clear ideas and vision of how you would accomplish your map. And then Drs. Whitehead and Mukherjee have kindly agreed to review your maps in template or in draft at a later date to help you complete them. Just an FYI too, there'll be a follow-up assessment mapping session in around the third week of January. Keep your eyes open for that. That'll help complete the process and finish your maps up with an assessment mapping exercise that will complete and the alignment of your assessment strategies and tools with your learning experiences. Okay, so we start off with Dr. Mukherjee.
Yeah, I think Dr. Whitehead is going to just say a couple of words before I start.
Absolutely.
Oh, just wanted to say welcome, and Lisa's actually outlined the objectives for the evening. Thanks everyone for coming. We're going to try to keep to the basics when we get into our breakout session. And as Lisa said, we'll, with a follow-up session, we can sort of cap it off by making sure that your maps are complete and of a level of sophistication adequate for, for your programs to use as a guideline for your curricular activities. And we'll add the assessment piece later and possibly some competencies. So we're just going to have the presentation, as we said, and we're going to break into the two groups, and it will be as interactive as possible with us being on Zoom. But we have the blank templates, and we're actually hoping you can actually get started on your maps tonight if you haven't done so already. So thanks, Lisa. So I'll hand it over to Som now, Dr. Mukherjee, and we'll start with the presentation part.
Okay, great. Thanks very much, Laurie. Can everybody hear me okay?
Yes.
Okay, perfect. So yeah, this is, I think, our third or fourth year that we've done the, I think third year that we've done the approach to curriculum mapping. And there'll certainly be lots of time for questions as we go, and there will be breakout rooms later on. But I hope by the end of tonight that I've been able to convince, that myself and Laurie have been able to convince you that curriculum maps are actually very helpful, that they're a really important tool to help you as program director and or program coordinator figure out where all of the pieces of your program and curriculum fit in. Hopefully we'll also be able to show you too that curriculum maps will help your trainees figure out where they have their EPAs evaluated and how they can relate all of the different rotations to the different EPAs that they need to be evaluated on. And then lastly, I think we hope to show you that there are a few different types of curriculum maps. So I think a lot of time has been spent preparing templates, filled out ones, and ones that are empty and blank, just to give you a starting point. So I think the objectives, as I said, number one, that to show you that these are important. Number two, to help you prepare for your transition to CBD. I know it's a scary transition, but these tools will actually make the whole transition a little bit more comfortable and a little bit easier to make sure that or to help you feel that you have a handle on where all the EPAs are going to fit into your curriculum. As I mentioned, there's different types of curriculum maps, and we'll go through that. But hopefully tonight you'll be able to choose which curriculum maps are going to be most suitable, most helpful for your program. We're not going to talk a lot about CanMEDS 2015. I think we might save that for the assessment workshop. But yeah, there is a 10-step process, like everything that's selling out there. There's always a 10-step process or 7-step process. So we'll introduce you to that tonight. We hope to have this, the presentation part of things much shorter than what's listed here, and that we can spend most of our time on the practical aspects of this. So this has been revised a bit, but maybe we can go to the next slide. So as I mentioned, curriculum mapping, most people really aren't quite clear exactly what they entail, what they are. You know, there's many, many different types of curriculum maps, and there's different definitions out there. So hopefully it'll become clear. You can go to the next slide. So Dr. Harden from Scotland actually was one of the original pioneers of CBME, and I just thought we could start with a simple definition. Curriculum mapping is what he called a visual representation of the curriculum, but it's also a way of looking at all of the different course content that you might have, like academic half days or other rounds, other educational experiences, but also how to incorporate assessment, you know, where your residents are going to be at what point in time on different rotations, and a timetable. So this will make more sense as we go. Next, yeah. So the question is, do you really need a curriculum map? Is there any way to get through CBME without one? I would argue probably not. I think it will make your life much easier if you have a map. It just helps you see where everything fits in, but also, you know, when it comes to EPAs and required training experiences, you need to see what rotations are going to be useful for evaluating which ones, but also to see that the required training experiences, are they coming in at the right stage of training? And really accreditation is, it's going to help you get through accreditation. And I think whoever's reviewing your program will see that you're very organized and that you know where everything is, but also that your residents are pretty confident in the whole process too. So next slide. Other key benefits. So I think not only is this good for program directors, it's also good for residents, but for you, it's going to help you figure out which EPAs are best evaluated during each of the different stages. You know, it's going to help you figure out what order of clinical rotations your residents should go through and where to put the training experiences so that it sort of coincides with what the Royal College has laid out for you in your own specialty. When residents look at these maps, they're going to be able to just look at the year at a glance, for example, which you do have an example of that. But that's very helpful. Our residents have each gotten a personalized year at a glance curriculum map, and it's something that they refer to all the time. And I should say program coordinators too also find this very helpful. Yeah, next slide. So what are the 10 steps? Here they are laid out 1 to 10, but I'm going to go through each one very briefly. Let's go next slide. So the first thing is that you don't have to do this by yourself. I mean, we have a relatively small program in medical oncology. We have 8 residents in total, 4 per year, and it's a 2-year program. So although there are a lot of really interested people in our program that could have helped with this, I just thought that for me, because of our small program, I sat down with our program coordinator and we started just putting everything together, and over, I'd say, a couple of weeks, we had most of the maps figured out. But you can involve faculty members of your residency training program. Sometimes there are interested residents or fellows who might want to be part of this. You could even consider faculty outside your program, depending on how big your program is. And of course, your program coordinator or administrator is going to be essential. So that's going to be your team. Next. So how do you start? Well, you review your program's curriculum, and there's different ways to do this, but you really want to make sure that you sit down, you go through all of the EPAs that are listed for your specialty, and think about where are you teaching them and how are you teaching them? Are you teaching them enough? Is there anything missing? So again, that required training experiences document that lists, for example, in our program, in the first 2 weeks of our training, all programs across Canada have to offer some chemotherapy suite emergency teaching. We have to have our residents rotate through our chemo suite pharmacy and spend time with the chemo suite nurses. So that's something that has to be done in a specified time. So you just want to go through the whole curriculum and make sure that everything is where it's supposed to be. And then you always want to be looking at your CanMEDS framework of medical expert and non-medical expert, but we'll get to that at a later point. So how do you do this? Well, there's different ways, you know, but you really want to create a diagram, a map, or a spreadsheet so that you can see where everything fits in. This way of doing things is actually quite complicated. That's why Lori and I have suggested that you start out with the most easy maps that are relatively straightforward to put together. So I would say that, you know, trying to take all aspects of your program and figuring out where they fit in. Most programs are pretty complex. I can't imagine like a 4 or 5 year program would be much more difficult to sort of figure out where everything fits in, because there would just be too many different moving pieces. But if you have a smaller program and you can say, okay, this molecular oncology course would fit well here, academic half days, these are the things we need to cover at the different stages. I think, you know, there's different ways to do it, but we'll show you today the introductory approach. Next. So you really do want to look at all the required training experiences. Your Royal College Specialty Committee would have put together a document that says there are required training experiences that you must provide for your trainees during a particular stage of training. And then there are other ones that are recommended. So that's something that you would want to go through and say, okay, where am I teaching these things? Next. And you want to make sure, we can go back one slide. You just want to make sure that your required training experiences and EPAs match up with the appropriate stages of training on your map. Just one example where I found this very helpful. So we only have one block of inpatient medical oncology in our whole 2 years. And that's something that needs to be taught in foundations. And foundations is only 5 blocks. And if you miss that window, then you've effectively not taught what you're supposed to teach at that point in time. And I had realized that for my residents' rotations, I actually had put their inpatient rotation much later in the year. And then I realized after doing the map that I needed to move that residence ward rotation to a different time. So I think it is helpful. There are some other examples I have here, but I think I've made the point. The other thing is you want to make sure that a particular rotation, say they're doing some type of surgery rotation, say, I don't know, maybe surgical oncology, for example, and that rotation, there's 10 EPAs that need to be evaluated, but you've only got 2 blocks to do 10 EPAs, whereas you've got other blocks where, you know, there's almost no EPAs that can be evaluated in that. So you really need to think through your curriculum and maybe even make some changes to the way that you're going to do things when you start CBME. We've certainly made some changes to our program, but making up these maps and seeing, okay, I've got, you know, so many EPAs, but I don't have enough rotations to evaluate them, because that can put a lot of stress on your residents when they have to have so many EPA assessments in a very short time, and other blocks where there's literally nothing to be evaluated on. Next. Yeah, so this one is just very basic, that, you know, when residents enter your program, they're going to have a transition to discipline, foundations, core, and transition to practice. So, you know, most of the EPAs are probably going to be assessed in foundations and core. And the first and fourth stages usually don't have a lot of EPAs that need to be assessed compared to the other 2. So just to be mindful of that. Next. And this is just saying the same thing, that you do want to make sure that the difficulty level of what you're teaching your residents is increasing in difficulty as you move from, say, foundations to core, etc. So that the EPA assessments also fit with that increasing level of difficulty. Next. And you want to ensure a logical progression of learning. I think I've already said this in a different way. So yeah. And then one of the things you'll see at the Year at a Glance tool that Lori's going to go over soon, you'll see that there are places where you can put what type of assessment that resident needs to have done and how they're going to be assessed. So is it Form 1? Is it a 360-degree feedback? So all of those things can be put on a map. So when a resident looks at this rotation, they know exactly what they need to do. Next. And then you also just want to cross-check everything that you're doing with your accreditation standards. And hopefully your program is not going through too many changes in your accreditation standards, so that it's relatively consistent and that everything fits together. And then the last point is attend workshops. So you guys are already ahead of the game. Next. And then the other thing is that because things can change, so we started in 2016, 2018, we actually went live with CBME. And what we found is that now we're starting to look at changing some of the EPAs, updating them. You know, instead of having, say, 35 assessments in breast cancer and colorectal cancer, you know, we're cutting back on some of the assessments in some places, but increasing them in other areas. So just to be aware that things will likely change and that you'll continue to meet with your specialty committees at the Royal College, and that what a map might look like today may be different from what it might look like next year or a few years from now. Next. So I think the key messages are that curriculum maps are going to really help you with your transition to CBME. There's a few different types. Lori's going to go through that now, and hopefully we can really, you know, figure out, you know, where you're having difficulties with your own curriculum maps, or even trying to figure out which ones are most suited to your program. Next. And I think that moves into Lori's part of the talk.
Great. Thanks, Joan. That's terrific. Were there any questions before we move on to just a couple of brief slides that I have? Good. Okay, we'll move on then. Next slide, please. So next slide, we're just going to buzz through some of this. This just sort of looks at where CBME planning goes and where you guys are probably at right now. And we're just approaching the curriculum mapping stage, but you can see that the Royal College, all the work that was done at the Royal College, at least for the program directors, you'll know that there's all this back work done that you did with the specialty committees. And you were guided along for EPAs and required training experiences and all that. The blue part that we're moving into now all falls on the program itself. Of course, as we stated, it has to go along with accreditation standards and everything, but we're at the point where curriculum mapping is sort of pretty much foundational for where you're going now in your program. Next. Next slide. Good, thanks. So also we really must look at the basics. So as I said, our objectives are to give you probably 3 types of maps today. If we can accomplish that, you guys are sort of getting some traction on 3 basic maps, I'll be really happy with that. And there's more complicated ones after that we can get into, or if someone asks about, I'm happy to show them. So I'm going to show you images of them, but I'm going to describe what they are. So the first one is Year at a Glance. And what it is Som stated, it's basically a calendar of events. And this is for the resident. It's the resident's roadmap. And I can tell you from being on the resident development committee for internal medicine and hearing the residents the last year and a half, or actually longer than that, because we did, you know, a run-in prior to our go live date, is navigation is the most difficult thing. They want to know where they're going and when and what they have to do. So it gives them stuff about what stage of training they're at, approximate idea of when they should be moving on, when their academic coach meeting should be, and how they should be a little bit before their competence committee reviews, those sorts of things. So we'll give you examples of those. And that'll look different whether you have a big program or a small program, and I'll describe that a little bit later. We've got examples of Som's program when he has under 10 residents, and I have 120. So the Year at a Glance looks different depending on what your program's all about. Next is direct mapping. And direct mapping, it means that you take each of your EPAs And then you select the rotations that will best, you would allow the resident to actually find a period of time where they can be assessed. So they would have an opportunity to be assessed, or they'd be able to learn that during that rotation. And I'll show you the map. It's a little bit hard to explain. Next slide, please. Next slide, thank you. Reverse mapping is sort of the opposite. So at this point, we're going to start with each rotation. We're not starting with the EPA. We're looking at a rotation that a resident will have within your program. Like for me, it might be the subspecialty of gastroenterology, for example. And then we look at within gastroenterology, what are the EPAs that are highly attainable? What are the target EPAs for the resident? And this is really helpful for the resident so that when they go on these different rotations, whether it's a chemo rotation, whether it's a community rotation, GI rotation, whatever it may be, they would know what that rotation, because we actually met with the various educators within that specialty and say, this is what we think we should be able to offer this if our resident comes to your rotation. What do you think? And then we made a map of that. And we'll show you that when we get to it. Mapping by competencies is a bit more complex, and we're not really going to talk about that too much today, unless someone asks. Next slide, please. And then there's some other documents as well. One of the surgical specialties had a compendium of all the training experiences during your program and put it in a huge map. Again, it's available for you to see on the link to Teams, but we're not going to deal with that today. And then there's a couple of other supplementary documents that I'll show you as we come along. So next slide, please. So let's start with the PGY1 year at a glance. So this is for medical oncology. And as I mentioned, there's only about 3 or 4 residents per year. So it's manageable for each resident to have his or her own map. And in the year at a glance, you can see the blocks. So the blocks are at the top going across the x-axis, 1 to 13. And then there's various things such as the stage of training, what rotation they're on, what EPAs you would expect them to tackle on that rotation, when their resident meetings are, anything that's important for your program would go down, and they can look at it and sort of see where things are happening approximately. And because that's designed for each individual resident, the rotation that they're on per block is filled in so they can actually see where they're at. Now, it's impossible in internal medicine to do that. Next slide, please. Actually, I'll show you, I've got it on, I don't have it with me, sorry. I don't have it on this presentation, but I'll show you the internal medicine one when we break out in our groups. The direct mapping template is the one that I mentioned where the basic thing you're looking at is your EPAs. So your EPAs are all listed by stage on the left-hand column, and across the top on the x-axis at the top, the various rotations that they would go through should be listed, and then you can indicate by an X whether or not they can be accomplished. For example, EPA number 1, you can see that it's obtained in rotation A, B, C, D, G. You can see how it's all mapped out there. This is helpful because you go down to EPA number 3, and you can see that EPA number 3 can only be accomplished in 2 of those rotations, HEMONC, and then various rotations listed by letter. So it's very helpful for you and the resident to have a look at that and say, well, geez, when I'm trying to do EPA number 3, I better make sure that I aim for it during the most appropriate rotation, because I'm not getting it on every rotation. Like EPA number 4, discussing serious news, can be obtained on any rotation. So if you miss it on one, you can pick it up on the other. Next slide, please. The reverse mapping is, as we said, is you actually take one of your residents' specific rotations. This is an internal medicine one. So for example, gastroenterology, and again by stage, because there's different learners going through it, different PGY1 to whatever. The target EPAs are listed there so that they know that the gastroenterology educators have met with me, and we together have decided that these are the EPAs that a resident should aim for when they're on. They're high yield, they're attainable, and it's important to get them on those rotations. You can add assessment in later and the tools and all that as well. Next slide, please. Now, one of the supplementary documents, and I haven't put it here because they're like 20 pages each, the orientation manual, that I'm sure you have orientation manuals for your various rotations. but residents find it as a really helpful roadmap, and just where they hang their coat, where they show up, who the staff are, who the admin staff, all that stuff needs to go in. But what we have right at the first 2 or 3 pages of the orientation manual is the reverse map. So again, if they do the orientation for gastroenterology at Juravinsky and the map's there, what pops up is what EPA should I be going for? Under that, it's listed how many should you be targeting per week. I'm going to try to get 2 per week. That would be my goal. So it's actually a good guide for the faculty as our learners come through, and it's a good guide, of course, for the residents. Next slide, please. This has been a document that I did that I didn't think was particularly useful until the residents saw it, and they said, oh my gosh, why didn't I see it earlier? Again, I mentioned how navigation is a big problem for them, and anxiety is a huge problem. And there's like an EPA frenzy, and they're always worried about, are they going to get their EPAs, and what's the rest of the class doing? Well, we know CBME is not time-based. It's supposed to be an individual, self-directed learning process, and everyone goes at their own speed. But the reality is that there's a loose expectation of when you should be moving from one stage to the next. And that's why there's sort of a gray zone in between. So this map shows the residents, for example, for transition to discipline, and within our 4-year program, it should be accomplished within the first 3 to 4 months, and that there's 3 EPAs, and then they move into foundations. And they know that the longest, just about all the EPAs and all programs, core seems to have the longest list in almost every program. And you can see that's blue, and they can see, okay, whew, I've got a lot of EPAs for core, but I got pretty much almost 2 years to do it. So they found that very helpful. It's all about helping the residents get through this. Next slide, please. Thank you. This is just something I mapped out as well, and it's not absolutely essential, but it has all the different rotations in our 3 years. Our 4-year program is a little bit separate, by the way. So this is the first 3 core years. And in no particular order, it shows all the rotations that we would expect for them to get in each year. And so this is what Sean was mentioning. It's really important to map up your EPAs with the rotations. So again, take the yellow here, which is transition to discipline, blocks 1, 2, and 3 for the PGY3. One of our EPAs is they have to show competence in several basic procedures. I think there's 5 procedures. So I absolutely have to put simulation in there and put them on a ward, which is the CTU, where they're going to get lots of chance to do procedures. So they would have no way of accomplishing the EPA within their transition to discipline if I didn't do that. So this sort of clues you in to whether or not your EPAs line up with your rotations. Next slide, please. So that's sort of it. We thought we would probably take a few questions now, but then break into our groups. It's 6 o'clock now, so we've got like it was an hour and a half, I think, to go through it if necessary. So any questions before we break out into our groups?
I just have one question. It's Suraj here. Can you map EPAs to external electives, or is that commonly done? And otherwise, I guess, how common is it that residents get EPAs assessed on external electives?
It's going to be easier as time goes on, because it depends on the external elective. It's one of our distributive centers from U of T, Western, or McMaster. As the programs convert and everyone's on the CBME, the community leaders in education are trying to get up to speed on EPAs. So it's been a stretch. You know, we're trying to get our own faculty educated about it. So you can expect it. It happens about half the time. We're very happy when it happens. External electives in academic centers, yes, because they're on par for the most part, unless they're going, say, if one of my residents goes to hematology or endocrine, which hasn't converted, it's a little bit trickier, as you know. It'll get easier over time. So we can map it to external electives, and it maybe takes a little bit of work to make sure that things are done at the other end. But like I say, I think it's realistic and will be easier to do in the next 2 or 3 years.
Yeah, I just want to say we've had some experience with that in medical oncology. For example, some of our residents have done community oncology, medical oncology electives, say up north, and depending on how motivated the faculty supervising is, and sometimes it requires some back and forth with the Royal College to get them added on to be able to do EPA evaluations. So it's pretty straightforward. It takes a few emails back and forth, but the residents are super keen to have as many opportunities to have EPAs evaluated. So part of it depends on the staff and are they willing to learn something new and submit an evaluation. So, but we've definitely done it in external electives.
So I'm getting the sense that basically it's something there that's a little bit individualized based on the elective, where it is, which supervisors there are, and maybe also needs a bit of planning with the individual resident in advance to kind of target the best EPAs for that particular experience. Is that fair to say?
Yes.
Yeah.
Our residents are our secret weapon, and we've really gone heavy on resident development and education. So they teach the staff. We're teaching the staff as well, for sure. But the residents, they know what to do, and the more they know what to do, and now especially with the one-step authentication, they can do the whole thing and walk the faculty through it. So that's going to be very helpful as they go outwards to their external electives, if it's up north or whatever. So yeah, it takes a lot of time, that's for sure. Any other questions?
Yeah, my question, sorry, is Anyton from ophthalmology. My question has been that we can do the same for international electives as well, because we do have residents that wants to go abroad, like England, where they may not be using the same system that we are using. But I know Europe is also advanced in CBME, but trying to plan the electives with them in terms of what EPAs needs to be achieved, why they are in electives may help. But like you said, our residents know best what they want. So I think maybe just thinking about it, that we can also apply this to international electives as well.
Yeah, I agree. We've done that. We have a number of residents who have gone abroad to do electives. And one thing we've done is sometimes there might be limitations, electronically, at least in our situation there was. So our resident printed off a bunch of EPA evaluations. The supervisor did them right on the spot in clinic, and then brought back all those evaluations. We confirmed that those were indeed the evaluations from the supervisor. And then my program coordinator entered them in on my behalf, and then I just signed off on them. So it is possible to do it.
Thanks.
Any other questions? I guess we're ready to break out then. You can ask tons of questions once we get on our individual groups as well. So I think, Allison, you know the assignments. I'm doing group 2. And Shom is doing group 1. So in my group, I have Bojana from pediatrics, Kelly from neonatal, Suraj from hematology, and Yohan from diagnostic imaging. And then the others are going with Shom. So Allison, are you able to?
Yes, sorry. I think people might have joined with different emails than I put you in the groups with, so I may just have to redo them on the spot, but it'll just take me a few moments, so I'm sorry if there's a bit of a delay.
Just a quick question, Lori. Did you plan to come back into the large group after you finish in your breakouts, or did you want to just wrap up from inside your small groups?
I think we'll see how things go. Allison's going to go back and forth, and we can correspond with her. If we're making really good headway in the 2 groups, I think that would be important. It'd be nice to get back for at least a 5 or a 10-minute large group gathering, but I guess we'll see how the timing goes. Is that okay with everyone? I mean, it's difficult to share maps as it is, and I don't want people to get confused if they've made headway in their own maps and then seeing someone who's half done another map sort of thing. But in terms of answering questions, I think Shom and I can do that within our own groups. So let's just play it by ear. Is that okay?
Sounds good.
Yeah, it's okay with me. Yeah.
We'll try to do a real quick wrap up if possible.
Perfect. I will open these rooms. You guys should all get a notification shortly.